My dear students of 4th year and 5th year of Adin Medical College, Assalamu alaikum. I am Dr. Luthful Khabir, Professor of Pediatrics. I will be discussing today on a topic that is very important for your examination and also very common after you become a doctor in your clinical practice. Let's start with the case summary. Shamim, a 5-month-old male child, presented with a runny nose, cough, difficult breathing over 5 days. He had bloated chest, respiratory 68 per minute, chest indrawing, central trachea, vesicular breath sound with prolonged expiration and bronchi. X-ray showed hyperinflation of lung fields and WBC counts 9,000 per cubic millimeter, that is normal. And this is a child, and this is X-ray chest showing hyperinflation and increased translucency. So diagnosis is bronchiolitis. Bronchiolitis was not in our memory till the year 2000 in Bangladesh. We were oblivious of bronchiolitis. We discovered bronchiolitis in Bangladesh in 2001. A study was conducted all over Bangladesh with more than 5,000 children under 5, and I found the commonest cause of respiratory distress in young children is bronchiolitis, not pneumonia. It was published in Pathology in 2010. Now, children are coming with cough and respiratory distress. The different diagnoses are 3. Number 1 is bronchiolitis, number 2 is pneumonia, and number 3 is asthma. Let us know Bangladesh. Bangladesh is a beautiful country, no doubt, and there is a baby boom, highly populated country, and both population and land are fertile. Bangabandhu, the father of the nation, and bronchiolitis, the commonest cause of hospitalization in hospital of children. Bronchiolitis. The format of presentation is with case definition, epidemiology, etiology, pathophysiology, clinical features, management update, and differential diagnosis, and some questions for exam. The case definition is a runny nose followed by respiratory distress with wheeze in a child below 2 years. 4 important points here. A runny nose, respiratory distress, wheeze, that is whistling sound coming from chest, and child below 2 years. And the first attack of wheeze in the first year of life is another case definition. Bronchiolitis is a major public health problem throughout the world, as declared by American family physician in 1997. So Bangladesh is no exception. And we published our first article on epidemic of bronchiolitis in Bangladesh Journal of Child Health in the year 2002. And this is the result of our study. The commonest cause is bronchiolitis 21%, pneumonia 11.5%, asthma 8%. BPA, bronchiolitis, pneumonia, and asthma. This is our experience at the Institute of Child and Mother Health in the year 2002. More than 60% of admitted children were bronchiolitis. One point is very important here. All children are in the mother's lap. There is all the children laptop babies, and no single children standing by the side of the mother. Now the risk factors are prematurity, younger age at presentation, non or minimal breastfeeding, congenital heart disease, chronic lung disease like bronchopulmonary dysplasia, immunodeficiency, exposure to tobacco and environmental pollution, and poverty. The etiology, the most important is respiratory syncytial virus. Now the second important cause is human metapneumovirus, and these two are important for you. Just other viruses are parainfluenza, influenza adenovirus, human bocavirus. Coronavirus also can cause bronchiolitis, but that is not COVID-19. It is OC43. So you should not fear of enterovirus and coronavirus. Bronchiolitis is the inflammation of the bronchioles, mostly by the virus. And RSV is transmitted by direct inoculation of large droplets or by self-inoculation infecting eyes and nose, like coronavirus. There is edema of the bronchial walls and plugging of the airways with mucus and exudates and cell debris, causing obstruction of the bronchioles. You see, there is edema of the bronchial wall and plugging of the airway by mucus and cell debris exudate. And in pathology, we find peribronchial lymph node infiltration and plugging of the lumen with exudate and cellular debris. And there is pathological changes causing hyperinflation, resulting in increased resistance, decreased compliance, increased work of breathing. Finally, ventilation perfusion mismatching, hypoxemia, and severe bronchiolitis may result in respiratory muscle fatigue, hyperventilation, and carbon dioxide retention, hypercapnia. Post-bronchiolitis symptoms, there may be recurrent wheeze in subsequent years or even can give rise to asthma. Now, symptoms. Age mostly below 1 year, preceding runny nose, cough, nasal blockade, inconceivable cry, restlessness, breathing difficulty, feeding difficulty, sleeping difficulty, no or low grade fever, loss of social smile, even convulsion in few cases. And signs, the child is not toxic, though very distressed. The nasal flaring, fast breathing, wheezing, full chest indrawing, vesicular vision, crepitation, rhonchi, impaired consciousness, and cyanosis. Investigation mostly not required. You can go for chest X-ray, WBC count mostly normal, C-reactive protein mildly raised. There may be sometimes hyponatremia, blood gas analysis, in severe cases hypoxemia, and you can find RSV virus in nasopharyngeal aspirate. And this is the X-ray. This is hyperinflation and increased translucency. আমি যেটা বলি বেশি বড় বেশি কালো লাংস, বড় মানে hyperinflation, কালো মানে increased translucency. If you can identify these two things, and it is easy for you to diagnose bronchiolitis. You see, there is no consolidation, either patchy or lower. And this is the kit for identification of RSV virus. It's not available commercially. This is we can do on scientific purpose only, research purpose. Now, management of bronchiolitis workshop held in 2004 with our respected national professor M.R. Khan, and is the director of primary healthcare, DGHS, and representative from UNICEF. And we formulated a guideline, national guideline ABC, asthma, bronchiolitis, and COPD. And now counseling on bronchiolitis, lungs are inverted tree-like organ supplying oxygen to and expelling carbon dioxide from the body. Virus affecting the bronchioles and a self-limiting disease causing narrowing of the terminal airways. The median length of stay in the hospital is just 4 days, and there may be recurrent wheeze or asthma in a significant number of cases. And you say the prognosis is excellent. Samiha, day 1 with hypoxemia, oxygen, and pulse oximetry. And the child just on the day 4 smiling. Return of smile is very rapid in case of bronchiolitis. So, laughing, coughing, and wheezing in a lab baby is bronchiolitis. কোলের শিশুর হাসি কাশি ও বুকে বাসি bronchiolitis. And management essentially unchanged over the last 40 years. Good supportive care remains the cornerstone. Oxygen being vital in those with hypoxemia. We should keep the head up and positioning the child, airway clearance, suctioning of the secretions from nasopharynx, using nasal valve syringe, previously giving a saline administration, and then should be a suction prior to feeding and inhalation therapy. And hydration and nutrition support is important. Feeding should be continued. So far, the oral feeding is possible, and then nasopharyngeal NG tube feeding can be given if oral feeding not possible. IV fluid can be given if oral and NG tube feeding not possible. Indications of hospitalization: moderate to severe respiratory distress, hypoxemia. Through pulse oximeter, the saturation is 90 or 92% or below. Poor feeding and dehydration, cyanosis, history of apnea, high risk infants like a child with congenital heart disease, immunodeficiency, and poor social circumstances. The child staying very far from the hospital or having poor economic support. And this is the pulse oximeter instrument for non-invasive assessment of oxygen status of the child. And this is very important for predicting disease severity. We label the child hypoxemic if the saturation is below 90 to 92%. We should give oxygen therapy, most important, given, and again I mentioned the saturation is less than 90 to 92%. It can be given through standard oxygen therapy, oxygen at 30 to 40%, warmed and humidified, delivered via nasal cannula or face mask or head box from a cylinder. And if the child is severely distressed, you can go for high flow oxygen therapy. And in case of severely distressed, not possible with management with high flow oxygen therapy, you can go for CPAP, continuous positive air pressure, and even the child may need PICU admission for ventilation. Chest physiotherapy is not routinely recommended. And pharmacological treatment is that Routine use of inhaled nebulized bronchodilator is contentious. Some group improves, some group there is no improvement, and some group even this nebulization is harmful. And mixed recommendations for nebulized epinephrine, and the use of hypertonic saline is now a safe medication, though its use also controversial. And should not give antibiotics to make the child toxic unduly, or antivirals or montelukast. In this regard, I would like to mention one study conducted by the Bangladeshi doctors with the largest sample size, a randomized controlled trial, 300 samples in 3 arms. In one arm, there was 100 children. We gave an ampicillin antibiotic, parenteral. In one arm gave erythromycin orally, and in one arm there is no antibiotic given, but supportive treatment given to all the groups, and we found there is same recovery in the 3 groups of children, and this was published in Acta Pediatrica, and also now you can find this in Cochrane database. This is a good achievement on the part of Bangladeshi doctors, and out of more than 700 studies, 7 studies are selected in this regard. Bronchiolitis antibiotic, and we have 2 studies in the 7 studies of Cochrane database. And nosocomial infection control, isolation of the patient, and careful attention to hand washing, and use of gowns, gloves, and even goggles. So what we are doing now in this corona crisis period. Other drugs not indicated like decongestant, antihistamine, dextromethorphan. And for prevention, Pembrolizumab, a humanized respiratory monoclonal antibody, can be given in high risk group. It is a costly drug, not available in Bangladesh. Now, complications are electrolyte imbalance, apnea, syndrome of inappropriate secretion of ATH, cardiac arrhythmia, encephalopathy, and finally respiratory failure. There are a lot of differential diagnoses, but I like to say that you mention most important is pneumonia, asthma, congenital heart disease. Now, problem with our doctors that they can't differentiate bronchiolitis and pneumonia, because these 2 diseases are sometimes of same age group, and clinical features are same, like cough, respiratory distress, fast breathing, chest indrawing, crepitation bronchi, and X is confusing. And this is further aggravated because of injection of pneumonia by IMCS syringe to the brain of the doctors while you were a student, and after being doctor you were exposed to different seminars, symposiums, mass media, training, literature, medical records, even by mothers about pneumonia, but seldom exposed to bronchiolitis. So there is a lot of confusion. A smart mother can influence a poor doctor. Is if a mother tells a child coming with respiratory distress, doctor, my child has developed pneumonia, please give injection. So if the doctor is poor, so for knowledge concern, then he will giving the injection ceftriaxone to the child. But a smart doctor will counsel the mother boldly that this is bronchiolitis, you don't need antibiotic. Just go back home and come if there are problems with severe distress. The child can't take food and the child becomes cyanosed. Now, why these 2 photographs here? nephrotic syndrome and bronchiolitis, the two diseases. But I like to mention here there is no examination of undergraduate, even postgraduate. The nephrotic syndrome is not given. A case of nephrotic syndrome not given. This is most important case, so we must remain grateful to nephrotic syndrome cases to become a doctor. And bronchiolitis is also important because when you pass become doctor, you'll find this case in the hospital most commonly. So you have to learn both nephrotic syndrome for passing, becoming doctor, and then for managing case, most common case in the hospital after being doctor. Now some questions for you. Name 3 diseases in children coming with cough and respiratory distress: bronchiolitis, pneumonia, asthma. Case definition of bronchiolitis: runny nose followed by respiratory distress associated with wheeze in the child between 2 years. Etiology of bronchiolitis: most important is respiratory syncytial virus, human metapneumovirus. Further, you can mention parainfluenza and adenovirus. Name 5 clinical features of bronchiolitis: no or low-grade fever, fast breathing, chest indrawing, inconsolable cry, feeding difficulty, rhonchi and crackles on auscultation. Mention 2 radiological features of bronchiolitis: hyperinflation, increased translucency. Mention 3 options of treatment of bronchiolitis: airway clearance, oxygen inhalation, nebulization with hypertonic saline or salbutamol, ensuring feeding, either breastfeeding, NGT feeding, or IV fluid. Now, how to counsel about bronchiolitis? Bronchiolitis, a self-limiting disease of lungs, inverted tree-like organ in the chest responsible for supplying oxygen to and removing carbon dioxide from our body. It is a viral infection of the stalk of a leaf. This is the leaf, this is the final part of tree, the alveoli, and this is stalk. And there is infection in this leaf, this is pneumonia, and infection in the stalk, that is by virus, that is bronchiolitis. And there is future possibility of recurrent wheeze or asthma. So thanks to all for your kind attention.